In this video, we can discuss about pharmacology of immunosuppressants. Here, we will discuss the definition, classification, mechanism of action, adverse drug reaction and uses of immunosuppressants. Let's start with the definition of immunosuppressants. Immunosuppressants are the drugs which will inhibit cellular or humoral or both type of immune response. So these drugs are mainly used in organ transplantation as well as autoimmune diseases. Now immunosuppressants are mainly classified into 5: calcineurin inhibitors like Cyclosporine and Tacrolimus, mTOR inhibitors like Sirolimus and Everolimus, then anti-proliferative drugs or cytotoxic drugs like azathioprine, methotrexate, cyclophosphamide and chlorambucil and mycophenolate mofetil, then glucocorticoids like prednisolone and other glucocorticoids like methylprednisolone, hydrocortisone, etc. And biological agents like tumor necrosis factor alpha inhibitors like endaracept, infliximab, then interleukin-1 receptor antagonists like anakinra, interleukin-2 receptor antagonists like taclizumab and basiliximab, anti-CD3 antibody like muromonab, and polygonal antibody like anti-thymocyte antibody and RHOD immunoglobulins. So this is the classification of immunosuppressants. Now before going to the pharmacology of each drugs, first we have to understand how the immunosuppression will occur in our body. So there is two types of immune response in our body: humoral immune response and cell-mediated immune response. In case of humoral immune response, this will start when antigen come in contact with the beta lymphocyte cells. So when it contact with the beta lymphocyte cell, this beta lymphocyte cell will be proliferated and differentiated to form plasma cell, and this plasma cell will produce antibody, and this antibody produced from the plasma cell will bind with the antigen and it will get neutralized. And some antigen, it may bind with the macrophages like antigen processing cell like macrophages when it is combined with the major histocompatibility cell, so that it will differentiate whether the antigen is self or non-self. So our body will consider anything that will come outside the body, and the MHC molecules will find whether it is self or non-self according to the differentiation of cell which is formed from the pluripotent cell which is formed during the fertilization during the conception time, when the ovum and sperm come and fuse to form fertilized zygote, and these zygote cells are known as pluripotent cell. The property of pluripotent cell is it can be differentiated into different kind of tissues like cardiac cells, bone, etc. So whether the cell is originated from the pluripotent cell, according to that it can be differentiated. So after finding with the MHC whether it is non-self, it will release some mediators like interleukin-1. So by the release of interleukin-1, it will activate the CD4 helper cell. So this helper cell will activate the helper T cells, and the helper T cells will start producing cytokines. And cytokines may enhance the proliferation of beta lymphocyte cell, and it can cause differentiation to form plasma cell and to produce antibody also. And the same cytokine also can mediate the cell-mediated immune response. So the cell-mediated immune response is from the precursor cell, or that is known as cytotoxic lymphocyte cell. So when an antigen bind with the cytotoxic lymphocyte cell, it will also produce interleukin-2. So that interleukin-2, it will activate the activated cytotoxic lymphocyte cell, and this will differentiate it into mature cytotoxic lymphocyte cell, and this will produce and this will bind with the antigen and it will lyse the foreign body. So this is the major immune response pathway in our body. Now, by understanding this, we can understand the mechanism of action of immunosuppressants. So, first we can discuss about the glucocorticoids. This glucocorticoid will inhibit the major histocompatibility expression, as well as it will inhibit the production of interleukin 1 as well as interleukin 2, which will respond to activate the cytokines, and cytokines have major two action. It will activate the beta lymphocyte cell as well as activated cytotoxic lymphocyte cell. So all this process will be inhibited, so the immune response will be suppressed. And in case of cytotoxic drugs like azathioprine, they will act at the clonal proliferation and differentiation of beta lymphocyte cell as well as activated cytotoxic lymphocyte cell also. And the cyclosporine and tacrolimus and sirolimus, they will inhibit the antigen stimulated activation as well as proliferation of the T cells, and expression of interleukin and cytokine also will be inhibited. So they will act here on the CD4 helper cell, and they will inhibit the immune response by inhibiting interleukin 2 as well as by inhibiting the proliferation of helper T cells. Now coming to the antibodies like muromonab CD3 as well as anti-thymocyte globulin specifically bind with the helper T cells, so that it will inhibit the secretion of interleukin as well as it will inhibit the secretion of cytokines. So as we mentioned before, cytokine have three effects. It will stimulate the proliferation of beta lymphocytes as well as it will stimulate the activation of cytotoxic lymphocyte cells also. So this is the immunosuppressant action in general. Now we can consider one by one. First classification of immunosuppressants is calcineurin inhibitors or specific T cell inhibitors like cyclosporine. So this is a cyclopeptide with 11 amino acids which is obtained from a fungus, and these calcineurin inhibitors like cyclosporine will act by inhibiting antigen stimulated activation as well as proliferation of helper T cells, as well as the expression of interleukin and other cytokines will be inhibited without affecting the suppressor T cell. So this will affect on the helper T cell, so thereby it will inhibit the release of interleukin as well as it will inhibit the release of cytokine also. Now what are the adverse drug reactions of cyclosporine? The important adverse drug reactions are nephrotoxicity, as well as it will impair the liver function, and there will be a sustained rise in blood pressure, and it may precipitate diabetics, anorexia and lethargy. It may cause hyperkalemia and hyperuricemia, and there will be a chance for opportunistic infection since the cyclosporine will suppress both T as well as B lymphocyte response. Then it may produce hirsutism, then gum hyperplasia, and tremor and seizures are the different adverse drug reactions of cyclosporine. Now coming to the drug interaction, as we mentioned before, in adverse drug reaction, cyclosporine will cause nephrotoxicity. So if we are combining cyclosporine with other nephrotoxic drugs like aminoglycoside, vancomycin and amphotericin B, which are antimicrobial agents, which may enhances the nephrotoxic action of cyclosporine, and cyclosporine will depress the renal function, so it can reduce the excretion of many drugs and it may cause toxicity of that kind of drugs. And some enzyme inducers like phenytoin, phenobarbital, rifampicin, these enzyme inducers will increases the metabolism of cyclosporine, thereby it will lower its blood concentration of cyclosporine. So it may cause rejection of transplantation. And cyclosporine is an enzyme inhibitor, so it will inhibit the metabolism of many drugs like erythromycin, ketoconazole and other related drugs. So it will increases the bioavailability of this kind of drugs, and it may cause toxicity of that drugs. And the potassium supplements and potassium sparing diuretic, when if you are using along with the cyclosporine, it may lead to hyperkalemia in patient on cyclosporine. Now, what are the uses of cyclosporine? It is mainly used in renal, hepatic, cardiac, bone marrow and other transplantation. For the immunosuppression in case of this kind of transplantation, we have to start the cyclosporine orally 12 hours before the transplantation, and we have to continue for as long as we need it. And it is a second line drug in many autoimmune diseases like rheumatoid arthritis, uveitis, bronchial asthma, inflammatory bowel diseases and dermatomyositis as well as psoriasis. And cyclosporine along with the corticosteroid or methotrexate, it will give good result when obtained in aplastic anemia also. So that is all about the cyclosporine. Now coming to another calcineurin inhibitors like tacrolimus, it will act by inhibiting same mechanism as that of cyclosporine. It will inhibit the antigen stimulated activation as well as proliferation of helper T cells, as well as it will inhibit the expression of interleukin and other cytokines without any affecting in the suppressor cell. And what is the advantage of tacrolimus over cyclosporine? It is 100 times more potent than cyclosporine, and the tacrolimus is administered orally as well as by IV infusion. Oral absorption may be variable and decreased by food. Now this is the site of action of tacrolimus. It will inhibit the CD4 helper T cells so that it will inhibit the interleukin as well as cytokine actions. Now coming to the adverse drug reaction of tacrolimus, it may precipitate diabetes, may cause neurotoxicity, alopecia and diarrhea, and dose limiting toxicity in renal. And these are mainly used in patients for the graft rejection or the transplant rejection, which are not suppressed by cyclosporine. Usually we will prefer cyclosporine. If the immunosuppression is not occurred during cyclosporine, we have to use tacrolimus. And this is particularly valuable in case of liver transplantation because its absorption do not depend on the bile, and it can be also used in fistulating Crohn's diseases also. Coming to next class of immunosuppressant, that is mTOR inhibitors like Sirolimus. This is a new and potent immunosuppressant which is a macrolide antibiotic like tacrolimus, which was early named as rapamycin. And the mechanism of action, this rapamycin or sirolimus will bind with the same immunophilin FK binding protein as that of tacrolimus, and but the sirolimus FKBP complex will inhibit another kinase which is known as mammalian target of rapamycin, which in short we can call it as mTOR, and it will not do not interact with the calcineurin. So this mTOR is an important link in cascade for signaling pathway which will lead to the proliferation and differentiation of T cell activated by interleukin as well as other cytokines. So they will act at the same mechanism as that of tacrolimus, but on different receptor or different kinase enzyme, that is the mammalian target of rapamycin. In the here also this is the responsible for the differentiation of CD4 cells. Now coming to the adverse drug reaction, it is not nephrotoxic when compared with the other tacrolimus. So sirolimus is not nephrotoxic, but it will suppress bone marrow suppression and it may cause thrombocytopenia. It may rise serum lipid in common. It may cause diarrhea, liver damage and pneumonitis. To the uses of sirolimus, it is used for prophylaxis and therapy of graft rejection reaction. Sirolimus can be used alone, but in generally it is combined with a low dose of cyclosporine, tacrolimus or corticosteroid. Sirolimus coated stents are being used to reduce the incidence of coronary artery restenosis by inhibiting endothelial proliferation at the site. So these are the uses of sirolimus.